Hi.
How are you?
Fine, and you?
Good. I'm good. I'm good. I'm good. I think we're actually live. I somehow I came straight onto the front of the stage. Did you come from backstage or did it show backstage,
I
Marina, or did it just come straight onto
I
live?
don't know.
Okay.
I I really don't know what I did. I had a link in my calendar and I just clicked on the link. So I don't know if there is
Okay. No worries. No worries. I think we're here. We're here. We're here. Do you need to get any water or are you good?
I'm good, thank you.
Are you
I
good?
just want to try to be sure that I can share my screen.
Okay, go ahead and
Yeah,
give it a
this is
shot.
because
Go ahead and make sure
so
it all
yeah,
works.
the pro okay.
Okay, let me make sure it works and we'll get all the technical stuff. Let's see. This is, yeah, I can see your screen.
Okay.
Perfect. Perfect.
Perfect. Okay.
Okay, perfect. All right. Well, hang on. Well, do you need anything? Because otherwise we get started in like about 4 minutes. If we start early, all those people like me that kind of struggle and show up on time instead of early, unlike, you wouldn't know what that's like. You're on the other side of that.
I do just lead whatever you like. So I follow your lead.
Oh, aren't you so sweet? Aren't you so sweet? Did you have a good ASCO?
I had a good ASCO. I'm still recovering from ASCO. Ah.
I get it. I get it. This is the first time I haven't gone in person, in I don't know, in a few years since before I started doing this. My son got married over the weekend,
Oh, nice.
and yeah, so we were celebrating that with the family. And so that was kind of it was a different kind of a training and a different kind of
Yeah.
wonderful and fun. And it's kind of funny because you walk away from doing something and all of a sudden, all of a sudden you realize, oh my gosh, cancer treatments, research, it all happens with or without me, right?
Yeah,
And so
this
I,
is
so I
true.
got so I got to
This
enjoy
is
the.
this is the same also for me that I am actively doing research in cancer. So I think that this is why I spend so much time in trying to teach the fellows so that we can amplify the the culture, the research in the people. And when I will be gone, there is a sort of heritage in this.
It is, and you're leaving a beautiful legacy of all the stuff that you bring to the space and everything. And it's kind of cool actually. To be able to see like all the research and all the opportunities that are kind of like coming across and getting to know y'all and whatever. And I don't know. It wasn't my dream to become a cancer advocate, and
I
so I
can
kind of felt
imagine.
so I kind of felt at it as opposed to like you probably always wanted to be a doctor and you accomplished your goal. Okay, this wasn't my original goal.
And what did you do in the past?
What did I do in the past? Well, right before like the cancer diagnosis and all the
Yeah.
advocacy and stuff, I had been like very active with being like heavily active in like as a volunteer, like raising my three kids. I used to, be like an accountant and work kind of with public accounting back in the day. And so it wasn't like I came into this with any skills other
Mhm.
than just being a mom that had worked with the PTA and worked with a bunch of like, volunteer things and whatever. And
Have
yeah,
three
and I
kids.
just, that was it. So it wasn't like I had any
So
sort
much
of,
work.
yeah, yeah. So but it doesn't feel like a before I don't know. I can't imagine not having this stuff in my life anymore. I mean, 8 years, right? 8 years lung cancer survivor. I can't imagine having this, not having this in my life anymore. Though never in a million years would I have signed up to have lung cancer. But I
Yeah.
cannot imagine taking it out of my life because I've met brilliant people like you, amazing like patients, researchers, advocates, and been able to like learn and understand and so it really is kind of like taking a wrong turn and finding all the very best of everything. And, you know, it's like, I don't know, it's kind of like I took a wrong turn and found a pot of gold or something that I wasn't looking for. It just really, it kind of really is. So anyway, but so I'm just, I'm just stalling until top of the hour. But anyway, okay, we probably should get this party started. And so, okay, so let me officially kick this off. Hi, everybody. I'm Terry Conneran with KRAS Kickers. I'm a lung cancer survivor, KRAS G12D for 8 years, but more importantly, I'm part of this amazing organization that it kind of found me, even though I'm kind of like the founder of KRAS Kickers. And so thank you for joining today. We are absolutely, and I mean everybody here is absolutely delighted to have with us today Dr. Marina Garasino, being able to talk about the ASCO 2025 and the clinical trial updates in KRAS. And you all, I put a poll out in our Facebook group to find out what you guys wanted to prioritize as best things, most important things. And you said clinical trial updates. So we are here today just doing what you need us to do and giving you the information you need. And I brought in somebody who I think if it wasn't for the cancer thing, I would want to be friends with. And I don't bring in people that it's like I don't really want to talk to. And so I'm really just truly honored to have you today with us, Marina. And thank you, Dr. Garasino. I'm not going to bore everybody with your huge list of titles and accomplishments and blah, 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 blah. You can look at her bio. So let me tell you the important thing is, she's brilliant. She's wonderful. She's in Chicago. And today you're going to get to hear a little bit about what happened at ASCO 2025. If you don't know what ASCO is, and I didn't used to, it's the big annual conference where basically, even though it says American, it really is the International Oncology Conference. And if anything's happening in the space in oncology, this is where everybody is for all the cancer and all the cancer types. And it covers everything from, oh my gosh, from like treatments and side effects to social issues and policy and just a myriad of things. But today we're going to be focusing on the KRAS clinical trial and the clinical trial updates. And so thank you so much for being here with us today. I'm going to let you kick off with the slides and we'll kind of go through that. And if you're okay with it, rather than me just letting you go through a slide, I'm just going to kind of jump in and say, hey, if I have questions and pelt you with questions as we go through, because I have like the memory of a goldfish. And so I need to be talking about what it is we're looking at right on time. Okay?
No. So thank you so much for inviting me and thank you for the work that you are doing because I think is amazing. And as you can understand from my accent, I'm full Italian. I came to the United States only 4 years ago. And when I was in Italy, I founded myself a group of lung cancer patients. And I would really love if you can connect with them because in Italy, the patient advocacies came later than in the United States. But you are so important to help other patients, but to help also the scientists, because sometimes the best ideas come from the patients, because maybe one patient can tell you, I experienced this side effect or something like that. So it's important to have a mutual collaboration. So I imagine that sorry, I go back to my so I guess that in the audience that there are people super experienced and people that maybe don't know what KRAS is. So this hour is totally for you, so feel free of interrupting, asking also what you believe is a stupid question. Don't be shy, because we are here to learn from each other, so and to help each other. Having said that, I don't know if you are aware, but in my career, KRAS has been always the center of my research since I was a very young scientist. And I was one of the first people who, more or about 15 years ago, published for the first time the different variants in lung cancer. At the time, KRAS was considered undruggable, so now it's fantastic to see this revolution. But at the time, we had only very few agents, and we were trying to improve the outcomes of the patients through what we had. And one of the first attempts was to learn that there were different variants and that the different variants could have a different also impact on the activity of different drugs. You see, for example, here that there is some difference. These are just cell lines on the activity of pemetrexed, which is one of the most important compound in adenocarcinoma. And there is also a difference in cisplatin, where you see that, for example, the G12V apparently is the most sensitive to ads. And also the same is also for Taxol. At the time we had the sorafenib that we thought had some, but then failed in the next clinical trials. I'm saying that because we should really move from the concept of KRAS to the concept of variants, and also to the concept that different variants can have a different impact in different tumors. So, for example, what is the G12C in lung cancer can be different from G12C in the patient advocacies came later than in the United States, but you are so important to help other patients, but to help also the scientists, because sometimes the best ideas come from the patients, because maybe one patient can tell you, I experienced this side effect or something like that. So it's important to have a mutual collaboration. So I imagine that in sorry, I go back to my so I guess that in the audience that there are people super experienced and people that maybe don't know what KRAS is. So this hour is totally for you, so feel free of interrupting, asking also what you believe is a stupid question. Don't be shy, because we are here to learn from each other, so and to help each other. Having said that, I don't know if you are aware, but in my career, KRAS has been always the center of my research since I was a very young scientist. And I was one of the first people who, more or about 15 years ago, published for the first time the different variants in lung cancer. At the time, KRAS was considered undruggable, so now it's fantastic to see this revolution. But at the time, we had only very few agents, and we were trying to improve the outcomes of the patients through what we had. And one of the first attempts was to learn that there were different variants and that the different variants could have a different also impact on the activity of different drugs. You see, for example, here that there is some difference. These are just cell lines on the activity of pemetrexed, which is one of the most important compound in adenocarcinoma. And there is also a difference in cisplatin, where you see that, for example, the G12V apparently is the most sensitive to ads. And also the same is also for Taxol. At the time we had the sorafenib that we thought would have some, but then failed in the next clinical trials. I'm saying that because we should really move from the concept of KRAS to the concept of variants, and also to the concept that different variants can have a different impact in different tumors. So, for example, what is the G12C in lung cancer can be different from G12C in colon cancer or in other tumors. Because the cancer is a big system, and as you will know in the next part of the presentation, also the co-mutations together with KRAS, they can play an important impact, and also the microenvironment in around the tumor cells can be very influenced by the type of mutations and also on the types of co-mutations, and can create also different activity to the immunotherapy. But this is just to show you how old was my love for KRAS. So this is a slide that I asked yesterday evening while I was preparing the slides for you. I asked the ChatGPT, how can I render easy the concept of what are the KRAS inhibitors and the covalent inhibitors, and what are the pan-KRAS inhibitors or other type that are using the on form. So I think this is very important, because you know very well that KRAS is not just important in tumor cells, but is important in normal cells. Anytime that we want to replicate some cells, sometimes we need the help of KRAS. And KRAS is important for not just tumor promotion, but also for cell promotion and cell proliferation in normal cells. So anytime that we target KRAS not just in the tumor cells, but we target KRAS in the entire cells. And why this is important for you? This is important because the first KRAS inhibitors, like for example, sotorasib and adagrasib, are targeting the inactive form of KRAS, the off form of KRAS. And this is possible. This is something, the yellow is something that I added to the ChatGPT image that I think is very clear. There is in the KRAS G12C, there is an amino acid that is called cysteine, that basically is, through a task, is able to change the conformation of the protein and can lead to the GDP inactive form. However, this cysteine is not present, for example, in G12V and G12D, and so this kind of approach is not feasible for all the variants, and is impossible to use this approach for all to target the entire family of KRAS. And this is also important because when you are targeting the inactive form, you are not targeting normal cells. And this is why when we target with the pan-KRAS inhibitors, we have to remember that sometimes we target also the normal cells. And this is why we can have off-target toxicity. For example, the skin toxicity, the diarrhea, other type of toxicities are related to the fact that we are targeting, through targeting the active type of the KRAS, we are targeting sometimes also the normal cells. Is it clear, Terry? You can interrupt me anytime.
No, it's clear. Okay, so KRAS, let me repeat back to you what it is that you're saying. And you are breaking up a little bit. I was hoping it was just me, but somebody posted you're breaking up. So I'm not sure if your internet's unstable.
I'm sorry.
No, it's just a little unstable. So I was hoping it was me and I went off video. That didn't seem to make a difference.
Let me try to move to another part of the house, closer to maybe the router.
Okay. All right. So what I'm hearing you say is KRAS is part of our normal cell, and we need it as a human being to exist because it's part of what we need to come on and go off, right? And the cysteine is what the C stands for in KRAS G12C, right? Okay,
Yeah.
and so when we're looking at a KRAS G12C inhibitor, obviously it's only for people that have the cysteine, the C, in their G12C, which is why, for example, it won't work in G12A or G12V or G12D or any of the other ones that we've got. Am I tracking?
Perfect.
Okay. And then we're gonna get in, and somebody's already posting trials like we'll get to the G12A. We have to kind of set the tone for what it is that we're talking about and what KRAS is. And so the important takeaway is we need KRAS to just exist. It's not like we can just go in and just suck it all out of our body, because then we're not going to be alive at all, because we need it to exist. And so we need to find a way to stop the KRAS from making the G12C, instead of making the right one, which should be in the, like, if it was right, it would be G12G. It would be G12 wild type is what that means.
Yeah. So KRAS, when it's mutated, is always on in the tumor. And in the normal cells can be off and can be on only when we need some proliferation. So what is important is that when we are targeting the off, we are targeting the tumor. When we are targeting the on, we are targeting also some normal cells that are on, because in that moment they need the proliferation. Okay, and this can come up with some toxicity. Okay, so this is an important concept. So G12C is clearly the most frequent alteration, in particular in lung cancer, is highly associated to the tobacco smoking, and is important, as I said before, that, for example, we know that there can be also the G12C in the normal cells, and but the G12C in the tumor is always on and activates constitutively the proliferation of the cells. So it's crucial to stop the G12C to avoid the continuous proliferation of the tumor. This is the story, I think, is sotorasib. I'm sure that there are many patients that are here in the call that they are still on sotorasib. And sotorasib is a great drug, was developed with a dose of 960 that we should discuss later. As you can see, there was a very good progression-free survival, so it means that the drug is active, and it didn't make it to show that there was a benefit in terms of overall survival compared to docetaxel, for many reasons that I'm not discussing here. But we are using, at least in the United States, with adagrasib, that I will show you in a moment, the drug, because it's active and you can leave docetaxel as a third line or in later line. I want just to say that I'm sure that you are familiar with the whole story of the right dose of sotorasib. The study started, by the way, at the University of Chicago. There was a little trial that compared the dose of 240 with the dose of 960 that showed that more or less were the same. And one of the updates of ASCO showed that in this meta-analysis, that was a poster, more or less what we see with the dose of 960 is that there is more shrinkage of the tumor, more reduction, but at the end of the day, the progression-free survival is the same. This is, I think, is important because sometimes I start with a full dose, and if a patient has toxicity, I can safely go down and give like 240 without changing the outcomes of the patients. So for all the patients who had a reduction of the drug, it's important to know that this does not have an impact on their treatment. This is the other very important trial that is adagrasib over docetaxel. And you see again that also adagrasib, which is very similar to sotorasib, there is a very good reduction of the hazard ratio of the progression-free survival, meaning that also with adagrasib, you can increase the progression. Reduce the progression. What is important is that the diarrhea is quite frequent in this population, as well as some nausea. The patients sometimes they refer some nausea. And consistently, I will not repeat for all the drugs, but for all the drugs, there is a constant report of increase of transaminases that are the liver enzymes. So in the beginning, we were super scared. 4 years ago, we were saying these drugs are not going anywhere because they have liver toxicity. And now we learned that you can just hold the treatment for some days, the transaminases go down, and you can restart the treatment again. And we are not worried anymore about this toxicity. Clearly, we have to fix maybe the diarrhea and the nausea, but the liver function that scared us was not important. Moving from adagrasib and sotorasib.
Can I ask a question?
Yeah.
Can I ask a question? Okay. So why is the liver one of the enzymes that it is that you're looking at? What does it matter? And if I'm just like off just a little bit, why do I have to change or stop my treatment?
So basically what we know is that we think that is a direct toxicity to the liver for which some liver cells are dying. We don't have a precise answer to this question, but as we believe that as you have the diarrhea, that is basically the death of some cells in the mucosa of your bowel, you can have the death of some cells in the liver. Just to tell you that this is not something for which one person can die, it's just a toxicity for which maybe we can just go down with the dose. This is important because when we combine these drugs with immunotherapy, as we will see in the next slides, you will see that in the beginning we were scared that was a toxicity of the immunotherapy, but now we believe that it is just a toxicity that is related to this kind of drugs. And you have just to hold the treatment for some days and restart the treatment again without creating too many problems. And the same is for the diarrhea. If the diarrhea is unbearable, you can stop the treatment, give the time to the patient to recover. If you are on sotorasib, you can decrease the dose and restart again.
Okay, well, it's good to know because it sounds very scary. It's like, okay, I don't want to give up the drug if it's not going to, but at the same time, if it's a tough balance. And so
Yeah,
it's good to know that it's like okay to stop the drug and then come back at it while we get things back under control. That's a very empowering moment for a patient.
yeah, I see, and it's an empowering moment also for the doctors because we want you to stay on the drug as much as you can. But the problem is that if we, for example, continue to give the drug and you increase the toxicity, maybe you have to stop over time. So when we see the toxicity, sometimes, we have experience now that we can hold the treatment for some days and then restart again. And sometimes the toxicity does not appear anymore. So this is why all these drugs are very new and is a learning curve for you as patients and is a learning curve for us as doctor. But the data that showed that if you go down with the dose, you don't have a negative impact on the outcomes, I think is very important for the patients, is very important for the doctors, because that we know that we are not creating problems on the longer term.
Do any of the
So,
treatments like manage it like, like the steroids or something to treat those things have any sort of impact? Or is it just make it better?
so this is another very good question. So we have these questions always in the discussions that we have in the scientific panels. Um, the reality is that we don't know. For example, at the University of Chicago, they told me just to hold the treatment unless the transaminases are very high. And they say just wait that the liver recovers. There are other hepatologists that are suggesting to give some steroids. So both options are fine. I think in the future we will learn even more whether the steroids are really important or not. What I do in my personal experience, if I don't have a stellar increase of transaminases, I hold the treatment for some days. I test it again. If I see that they are trending down, I restart the treatment again. So I give just the time to the liver to recover just a bit. Yeah. Is, do you have other
Okay, no,
questions?
it's no, no,
Yeah.
it's all good. It just kind of, and I know it keeps coming up. And as a patient, it's like I feel like I'm failing. Okay, when I'm
Yeah.
not, when my results aren't good, and it's nothing I can do about my liver enzymes really. But I also knowing that I can start or stop, and the steroids are not making. If there's making a big difference, then y'all would have caught it by now, right? But it's not making some sweeping difference. It's there's nuance to it. So, so stay tuned. If you
Yeah.
need it, if you need it and your doctor's prescribing it, have that conversation because it's why they call it personalized medicine. You need to know and you need to have that conversation what's best for you individually.
Exactly. And yeah, no, exactly. And the other message that I would like to give is that because the patients are scared, and I see that point, they start to take a lot of compounds prescribed maybe by, herbal medications or these kind of things. I really love this kind of medications, but don't auto-prescribe the medications. Go always back to your oncologist because this kind of drugs can decrease the concentration of the drugs. So we have, for example, we are working with our pharmacists. If person is important to have a very transparent relationship with your oncologist because if, for example, we check all the interactions. So if there are interactions, it's better to hold. And if there are no interaction, you can continue. But never, never, never take something for which you don't know if there are interactions or not.
Thank you for
I think this
highlighting
is
that. Thank you for highlighting that, because it's a very, very important point. Okay, just because it's natural and just because you can buy it over the counter does not necessarily mean it's going to play nice in your body with these other treatments and these other things. And especially if you're on in particular, if you're on a clinical trial, you need to let the doctor know what's going on. It's not always the guilty culprit of grapefruit juice. Sometimes it's like an herbal tea, that there's things that can go wonky. And when you're like, oh yes, but it's natural. So is arsenic, and that'll kill you. And even, and as good as water is for us, you can also drown. So you need to know what it is that you're dealing with as a patient. So please, please have that conversation. And thank you so much for bringing that up.
Yeah, and by the way, we know very well that the patients are taking this kind of things. So don't be shy. We are not terrible people. We know very well that you are afraid about your tumor. So it's better to do together a better job and share what you are taking. So we will not blame you for taking something more. The other part, to move in the other part of the presentation, this was recently published a year ago in the New England Journal of Medicine. There is a new wave of new drugs. This is one that is divorasib, for which there is really an impressive response rate the shrinkage of the tumor with this new compound that is called divorasib. As you can see, there is a brilliant progression-free survival of about 13 months, which is longer compared to what we have seen with adagrasib and sotorasib. And again, you can see more or less the same side effects compared to adagrasib and sotorasib. So nausea, diarrhea, some increase of the transaminases. So just to say that we are also moving to a new generation of tyrosine kinase inhibitors. There is also another form of drugs that are targeting, as I told you before, the on form of KRAS. This is a drug that is called elironrasib, that is done by Revolution Medicine, which is a company that are largely invested in KRAS. And again, you see a very zero progressive disease, 50% of partial responses, and 50% of stable disease. So clearly, as you can see here, the number of patients treated are not so many. So we need clearly more results to see the toxicity and see the efficacy of this drug. Here at ASCO was presented another drug that is called sosimerasib, is an Asian compound. And again, you see 52% of response rate. The median follow-up is 6.8 months. Remember that, for example, divorasib is about 12 months. So all these compounds are important. And I think in the future, maybe we will have to understand how to sequence these compounds. But clearly, we will start with the best in class. However, you see that there is a pretty good disease control rate, and there is some patients, as you can see, they have a very long responses, but the median follow-up is very, very short, and so it's very difficult to say if this drug will be better or not compared to the other.
Okay, so just for clarification, I'm sorry to interrupt. Just for clarification, these are all G12C drugs, right?
Yeah.
For G12C.
Yes.
Okay, I just want to get clarity, and just to keep everybody also on track, G12C drugs do not work for the non-G12C patients because it's a different typo. And so it's a different problem in your body. Your body has a different type of a protein. And so It's like, I know as a patient, I kept thinking, but I'm only one letter off. No, you're not one letter off. It's just a different abbreviation. And it's kind of like my house key, even though I live next door to my neighbor, my house key doesn't work over there. And that doesn't give me the right to go, like, watch their TV and eat their food.
Perfect. And remember the cysteine. C is for cysteine. If you don't have the cysteine, the drug doesn't attack and doesn't create any kind of benefit, at least for the covalent inhibitors. I'm doing the entire G12C, and then we can move to the G12D and the pan-KRAS. I think is important and was updated at ASCO. And I was so happy that I had the privilege to present, in my opinion, the most important part at the LCC in Paris 3 months ago. But this is a combination of pembrolizumab, which is an anti-PD-1 inhibitor that is a standard of care, plus adagrasib, which is the KRAS inhibitors. So we are trying to put together the best of the best. Also because it's important for you to remember that in general, the patients with KRAS G12C mutation respond very, very well also to the immunotherapy. So you can put together the best immunotherapy and the KRAS inhibitor. This trial was done not just for the PD-L1 more than 50, but was done for all the patients PD-L1 stratified by PD-L1 expression. And you can see here that the benefit in those patients who have PD-L1 more than 50% is really, really impressive. I have patients on this trial, and you can see that they are without a progression for almost 3 years. So I think this is really, really amazing. And for the other patients, presented the data, I called the company and I said, "Are you sure to have to have done the right Kaplan-Meier curves? Because PD-L1 more than 50% with pembro alone, the progression-free survival is less than 10 months." And here we have 27.7. So basically we are triplicating the progression-free survival of these patients. And so I'm super proud to say, I want to see if someone will win adagrasib and pembro. How can, and you see that the majority of the benefit is clearly in the population of patients with PD-L1 more than 50, and there is less benefit in the population with less than 1%. And in the middle, we have a 149. So clearly, we really want to move the pembro and adagrasib in the first line setting, because we are sure that we are making a big breakthrough. We have a clinical trial that is ongoing, that is Crystal 7, is recruiting now, and is open in many sites. We have opened the trial also at the University of Chicago. So for the patients who are still treatment naive and have PD-L1 more than 50, I think this trial really represents a unique opportunity, because you can't have in this moment the possibility to combine adagrasib and pembro, because it's not a treatment that is FDA approved. Is it? Do you have questions on this? I think that this is really an important step for
it's incredibly
the
important.
patient.
So let me see if I understand correctly. Okay. And so pembro, which is immunotherapy, right? And that's just the non-branded name that has to be used in these presentations. Okay, so pembrolizumab, which is the most common and approved immunotherapy that most patients get put on. That is just in and of itself. I think if you go back, let's see, was it on this slide or the previous slide? It has, what did you say? It was 10 months, progression-free survival, 8 months? 10 months. Okay, so it's 10 months. Okay, I remember. Okay, and then, but then if you're on pembro immunotherapy, in addition to the adagrasib, which is from this Crystal 7 trial, you're showing 27 months progression-free survival. So progression-free survival means, well, I'll let you explain. You're the doctor. You explain. What does progression-free survival mean?
Progression-free survival is the time from when you start the treatment and when the treatment stops working. So, for example, if I started today thinking that these results will be replicated in the Crystal 7. So if I started today, I am supposed that in 50% of the patients, the drug will work 27 months, which is, the 2 years and a half. And then in 2 years and a half, you will have new generations of KRAS inhibitors. I can bet that they will be already approved, with which you can continue maybe another very long time on this kind of drugs. So the time that you gain in the first line is a time that the patients gain also in the research, because in 3 years, there will be a revolution of these drugs.
I think that's a really important point that needs to kind of be driven home, that I didn't understand just coming in and getting diagnosed. It's a matter of you're kind of like I don't know. It's kind of like buying a car. I know my car is not going to last me forever. Okay. But I mean, I didn't go into buying, I promise you, I did not buy that car to last me forever. I promise you that. But you buy a car and you just really don't expect it to last an entire lifetime. But it is going to be buying me enough time to get from point A to point B. Now, whether that means if, on average, I don't know, a car, I don't know, this is just off the cuff, I'm just pulling these numbers. But it's like on average, a car may last you, I don't know, like 5 years. Now, some people, I mean, they're getting 2 years out of it. Okay, but it's not forever. And then at the end of that time, you're looking for a new car. But at the same time, you don't wait until the whole thing falls apart. You're looking for what's next as you're starting to see it kind of wear down. And I think that's very much where the survival and the strategy kind of like come together. Right? You're like a frog. You're looking for leapfrogging from this point to the next point. And what are we going to be doing? And so, in 2.5 to 5 years time, I mean, we've watched life expectancy on like a stage 3. I know stage 3 lung cancer off the top of my head. Of the stage 3 lung cancer patient go from like an 18% to 25%. Okay. In like less than a 5-year span of time. And now we're closer to 30%. Okay, that number's going the right direction. And so as we kind of just keep riding that wave for what's next and kind of keep looking forward, it's not that then I fall off the planet. It's a matter of I've got something that's next and we're buying time for that next thing. Is that
Perfect.
Make sense?
You said it very well. So this is perfect.
Okay, so how could I, as a patient, is this like an approved thing? How do I come at it? If I'm a G12C patient and I'm just newly diagnosed, I'm a G12C, and statistically, it's mostly lung cancer that have a KRAS G12C. So yes. If I'm a G12C lung cancer patient, where does this fall? Is this something I should look at first? How do I know?
So yes, when the doctor will give you the diagnosis, basically they will give you a number which is PD-L1 that represents your sensitivity to the immunotherapy, and will give you, if you have a KRAS mutation, the variant. If you have PD-L1 high and KRAS G12C, you can find the center where this trial is active, and you can be part of this trial. Just to let you know that you can't start the trial if you are already taking another medication. So this must be decided in the beginning of the diagnosis. And if you are already, for example, on pembrolizumab, just move to another maybe clinical trial in the second line that is randomizing, for example, divorasib over sotorasib, because in that way you might have access to the new compounds. So I would stress how important is the participation to clinical trials now, because this can really give you a lot of opportunities. Moving, because we have really a lot of things to say. Adagrasib is not the only one. There are trials also with another compound that is very, very active, that is called olomorasib. The results were updated the first time in WC last year. And you can see here, so these are figures that maybe you are not familiar. Each line is a patient. But again, you can see here that there is, when you see below, it means that the patient is responding to the treatment. When you see a spike that is upper in the 0 part, the patient is progressing. You see here, again, impressively, the majority of the patients are responding also to the combination of olomorasib and pembrolizumab and chemotherapy. So with the future will be to decide. I think that the future, if I have to give a prediction, maybe I'm wrong, so take it with a grain of salt, but will be that maybe in the PD-L1 more than 50, the trials will be positive with the combination of the KRAS inhibitors and immunotherapy, while in those with PD-L1 less than 50, we will need also to add some chemotherapy. So it will be like a sort of quadruplet with chemotherapy and the immunotherapy and the KRAS inhibitors. Again, this is a part that was presented at ASCO. This is again the combination of olomorasib and pembro. Patients were randomized, were included in this trial, and you see again incredible results. And when you see that the progression-free survival is not reached yet, is because the results are really good, because it means that all the patients are still on the treatment. Then whether olomorasib is better to adagrasib, we don't know. We need the clinical trials in the future that will be able to say if olomorasib is better than adagrasib. But adagrasib, 27 months is really a huge benefit. And you see that here we still have patients ongoing, and the follow-up of this trial is less than the other one. But again, you see incredible duration of response and incredible progression-free survival. This means that the majority of the patients here are still on treatment and they didn't have a progression. And again, this just to say, try if you have a diagnosis just to apply. The Sunray is the trial that is giving you the opportunity to receive olomorasib and pembro, or the combination with chemotherapy, olomorasib and pembro. This trial is recruiting in many centers around the world. We have the same trial also at the University of Chicago. So try to join these trials because they can give you incredible opportunities. There is also one part that is also for with the cetuximab. Cetuximab is an EGFR monoclonal antibody. We know that there is, I don't have the time to explain very well, but we know that EGFR has an important modulation of KRAS. And so we have seen last year some results of cetuximab and sotorasib that were incredibly good. And here in this ASCO, we have seen some results of the combination with cetuximab and olomorasib. And again, you see that only 2 patients in the entire trial had a progression of the tumor from the beginning. And again, half of the patients had a great response on the combination of the 2 drugs. So this again, only in clinical trials can represent a good opportunity. And again, you see that there is a progression-free survival of 7.4 months that now when I told you 27, you say, what is this? But again, this is a very interesting possibility because the patients were pretreated before and there, as you can see here, we don't have the immunotherapy. So again, this combination can be promising again in further lines. There is another compound that is again very interesting for the G12C that is, I don't know if it has already a name, but is called the Merck 1084. That again, you see, is exploring multiple cohorts combined with immunotherapy again. And again, this is another possibility to receive a very good KRAS inhibitor together with immunotherapy in a clinical trial. And again, also here you see that independently by the PD-L1 expression, the majority of the patients responded to this combination. So, and you see again with different doses, you have different combination. And the response rate in PD-L1 more than 50%, that is the population that I showed you before, the response rate, meaning the tumor reduction is in 86% of the patients. And the disease control rate is incredibly high, is in about 100% of the patients. So just to reiterate again that at the diagnosis, if you have the possibility, just join one of these programs because the results are amazing and the duration of response is amazing again. We don't know if there is one best, at least yet, but we know that the combination with immunotherapy is really, really important.
Before we go jump into that, hang on one second.
Yes.
Before we go jump into G12D, and I really a lot to cover, and so I'm going to contain myself. But one quick question: if you are on like one of the other drug treatments, so say you started on sotorasib and you have progression, is one of these other drugs a consideration, or is there a trial that somebody could be looking at?
So this is an area of research. So we are learning now how to continue after the resistance of the first line of KRAS inhibitors. It is possible that as for all the other targets, we will have KRAS dependent resistance, and so maybe the pan-KRAS inhibitors will play a role, or combination with other agents will play a role, or other chemotherapies or other agents in this field. So if you start with a drug like sotorasib and adagrasib, there are clinical trials that are considering now other KRAS inhibitors in combination with other drugs. For example, the SHP inhibitors or the pan-KRAS inhibitors or other compounds. We don't have yet a sequence for which we know what you can do after adagrasib and sotorasib, that are the trials that are in the market now.
Okay, and I saw that there was something else around CNS and brain mets. Was there one drug that is showing anything more forward in that way?
So I think that all the drugs, we are still learning if there is drug penetration and how much drug penetration there is. We know that there is, some activity in them. It is possible that the new compounds, they have more in the drug penetration. But I think that in the daily clinic, the discussion with the radiation oncologist is still crucial to decide whether to do the radiation or try to do a drug and maybe do the radiation right after. I don't know if I answered your question.
Well, I think I remember that like adagrasib had something, it was like they were showing that pre-treated brain mets, that people were, I don't know, statistically less inclined to have recurrent brain mets or something like that. I'm kind of mangling something up in my head.
No, you are remembering very well. There is a subgroup analysis that showed that there is activity in the brain. And there is maybe also some prevention in having some new brain mets. We don't know if all these compounds have the same activity. And again, the activity of these drugs in the brain is not 100%. So it is important anytime to discuss with the radiation oncologist whether to do the radiation or to continue with these compounds.
Okay, perfect. Thank you.
Okay. Are there other questions? Then I will do a part on the commutations and all the biomarkers, but I put everything that we had for the different mutations before so that we can go step by step.
Perfect.
So G12D is clearly another type of mutation, less frequent in lung cancer, but is still present also in lung cancer. Apparently has a better prognosis compared to G12C in the series. But we still sometimes, 3 years ago, we were saying, why has the G12D and not the G12C? Now we are happy to see that there are drugs that are working also in the G12D. Just I want to reiterate what I said before, that these compounds are available in clinical trials and they are not commercialized. So you can't go tomorrow morning to your doctor and say, please prescribe me the G12D inhibitors, because none of them is approved in lung cancer. But you can see that this one that is called sorry, I have to went back. Zoldonrasib is potent, and the majority of the patients again had a response to this tumor. The response rate, the shrinkage happened in 61% of the patients. But again, the number of patients included here are not that many. So this is why we need more research and more patients enrolled to understand exactly the duration of the response and the response rate. But clearly, these results that were presented 2 months ago are incredibly good, and there is a response rate in the majority of the patients. And again, this is another compound targeting the G12C, and the G12C is again another, this compound is called GFH375, was presented 3 days ago. and again is a highly selective and potent KRAS G12D inhibitor, and has a particular mechanism of action because are targeting simultaneously the on state and the off state. This is an Asian trial. And you can see that what I was saying before, that when you are targeting the on activity of the KRAS, there is some more toxicity. For example, you see more diarrhea in 69% of the patients. You see in 30% of the patients, again, liver enzymes, and there is always some nausea and vomiting. What when as doctors, we evaluated the activity, we evaluated the activity with the grade 3. The grade 3 means that there is a severe toxicity. But as you can see here, the severe toxicity is only in 5% of the patients. So the toxicity is still manageable with a good education, with some Imodium. But I recognize that for a patient, having a constant diarrhea can, be a negative, have a negative impact in the quality of life because maybe you have reduced your social life. So it's important to participate in these trials. It's important also as patient advocacy to help on helping the doctors to understand very well which is the impact on your quality of life. And maybe like as we did for sotorasib, also to do clinical trials that are reducing the doses of this kind of compounds with a similar activity. But
So
again,
let
the benefit.
me ask a question. Let me ask a question. So you're saying it's really important that we tell you how bad the diarrhea is and what it is that we're living with, okay? Because as a patient, we get scared to say anything because we want to keep on the drug because it's working or whatever. But if I can't leave the bathroom, it's not much of a life, and I need to pick up my kids. So just putting that out there and underscoring what you're saying. So keep rolling. I'm doing my best to interrupt.
No, thank you so much, because I think that I know very well that sometimes the patients are scared. And we want to know, because we want to know also because the real world data sometimes are different from what we observe in the clinical trials. And just to show you this example, you see that the dose of 400, 600, and 300, they have response with different doses. So we have to, big part of the research in the future will be to understand which is the optimal dose that can give you also a long life, but also a life with a very good quality. So please, please, please tell us for you and tell us for the patients. What you see here, that there is also benefit in the pancreatic tumors that are a tumor where you can see a lot of KRAS G12D. Moving to the pan-KRAS inhibitors that I think are the hype of the year. Basically, the KRAS, the pan-KRAS inhibitors are targeting selectively the RAS-on function. And this is important, as I told you multiple times today before, because you can have some toxicity, because you are targeting always also some cells that they are using RAS to replicate for their physiological function and for their normal function, and I said in the beginning. But again, also the pan-KRAS inhibitors, this is again one from Revolution Medicine that was very recently presented, and there is a response rate of 38% and a median progression-free survival of 9.8 months And what is very important to say is that these patients were highly pretreated. And so again, participating in clinical trials that are offering this kind of drugs is very, very important to have possibilities and active compounds. There is a trial that we will have also at the University of Chicago that is starting around the world that now is randomizing this drug independently by the KRAS mutation you have, and is comparing this pan-KRAS inhibitor over docetaxel. I think that the majority of the enrollment will be done in the space outside the KRAS G12C, will be done mostly in those patients without the KRAS G12C. But if you have a trial in your center that is randomizing this compound over docetaxel, is good because we know that the drug is active as well.
Before we jump, let me ask a question. Okay, could you go back one slide? So whenever we see G12X, okay, as a patient, there's not an X type of mutation. Could you kind of explain to me what a G12X is?
So G12X is everything that is not specifically C. So for example, you can have a G12, but instead of C, you can have G12D, you can have another type of G12, or you can have, for example, the G13 that can be a variant that does not have the cysteine, but have a different type of amino acid involved. So every KRAS mutation, basically.
So like when we're looking at that criteria, we're seeing RAS, which could be NRAS or HRAS or KRAS. It could be G12A, it could be, it says G13R, it could be Q61H, it could be any one of those, okay?
Exactly.
And so that's part of the eligibility criteria. Obviously, there's more eligibility criteria and other things too. And somebody just posted a question about G12H. Well, G12H I'm sorry, I said that wrong. Q12H. I haven't seen Q12H if I'm being honest off the top of my head. But there might be things that are around a solid tumor. So with that, and we're blowing up the questions here. I'm gonna let you keep rolling, or we'll never get through them all. So you keep going. You're rocking.
Yes. And there is a question. So I think we should go to the eligibility criteria and see case by case if you can be included or not. And I agree that I didn't put it because I was more focused on the novelties presented at ASCO, but there is also this trial of daraxonrasib, which is in previously treated patients with KRAS mutation. And you can see here in the link, someone posted the link to the clinicaltrials.gov, where you can see also all the centers who have this kind of drug. Thank you for posting it. And then I think we can move, unless you have other questions, we can move just a bit to how we can select and the biomarkers that are a never-ending story in lung cancer that I think are really, really important. So as I told you before in the beginning, the G12C and also all the other mutations, they can have also other commutations together. and the activity of the first generation and maybe also of the next generation of the KRAS inhibitors can be dependent also on the presence or the absence of this kind of alterations. This is a paper that was published a couple of years ago by the group of MD Anderson in cancer discovery. And you can see here that the presence of a mutation that is called the KEAP1 and also a mutation that is called the CDK and they can have SMARC4, they can have an impact on the activity of the first generation of covalent KRAS inhibitors. So it's important when you see your doctor that the doctor does not see just the KRAS and go, but can have a discussion with the patients on which are the other variables that contribute to the length of the treatment. For example, in this case, you see that if you have a mutation, your time on treatment can be from 7 months to 13 months. So this kind of mutations can help to understand how can be the durability of your drug. Was published a week ago, this very important paper by Skoulidis, that is again the same group of MD Anderson. And I think that what they found, I think is very, very interesting. They saw that if you have what we call TTF, that is a test that we do with immunohistochemistry in all patients with adenocarcinoma, so it's not something that we have to reinvent, can distinguish very, very well those patients who have activity, more activity with the KRAS inhibitors and those who don't. I think that the reason is then when you have the absence of the TTF1 is because your tumor is highly indifferentiated and in general has less dependence on KRAS, and because you have so many alterations, sometimes the KRAS inhibitors don't work so well. So more than an inactivity of KRAS, I think is more a test that is able to understand how much your tumor is indifferentiated or not. But again, this is another thing that tomorrow morning I will use in my clinical practice to predict and the activity of these drugs in the patients. And this is another one that is called NRF2. This is another drug that in general, another gene that in general we test with NGS, but not all the patients they test this compound. But again, when NRF2 is low expressed, the prognosis of the patients is much better. So these things are all things together with LKB1 that must be taken into account to predict the activity of the compounds and potentially also in the future to stratify the clinical trials, and maybe they will be helpful also to understand if a patient is better with pan-KRAS inhibitors or is better with the simple G12C covalent inhibitors. These are all questions without solutions, but just to tell you where the research is going in the future. And again, in ASCO was presented this by was presented this very important trial in the lung map space that enrolled patients with co-mutations P53 or with STK11 or with other mutations. All patients were treated with sotorasib with a full dose. And again, you can see that there can be a different activity if you have commutations or if you don't have commutations. So if you don't have commutations, I think that the activity can be higher compared to those patients who do not have any kind of commutation. But again, you see that here you can have also, if you have a STK11 as a commutation, you still have some activity. So the disease control rate is 60%. So don't think that if you have a LKB1 or KEAP1, you don't have any kind of activity, because maybe the response rate is lower. The response rate is 16% compared to other commutation, but you can still have some activity. So the commutations are more important to define the prognosis of the patients rather than the type of the treatment. I don't know if I was clear.
So let me reiterate that. So make sure that I'm understanding. Okay. And so I don't interrupt you because you're not clear. I'm interrupting you to make sure I'm understanding. Okay.
Okay.
All right. And so I'm kind of like, you know, I have the easy job, just be a dumb patient. So, okay. So what you're saying is if you have STK11, it's not necessarily a treatment decision. It's just showing you like an overall trend of, okay. Right?
Exactly.
Is that correct? Okay. And then some of these other things like STK11, and I should have written down the new scolitis things that they had. I did. Yeah. Okay. I didn't write them down, and I haven't memorized them yet. Are those something that are commonly like tested for? Do you guys do that at University of Chicago? Is that something that you guys are normally looking at?
So TTF1 is commonly done everywhere because it's the way on how we define if a patient has an adenocarcinoma. So it's commonly tested. In general, in the last years, we are testing also for STK11, that is also called LKB1, is a synonymous, more or less everywhere, because it's a way in which we decide which kind of immunotherapy we give. So I think that in the majority of the centers, it's possible that when you have the results of your NGS, you have all this kind of results.
Okay. And I'm going to let you, because I can see we only have like 15 minutes left. And so I'm going to let you just roll unless you see me exploding out of my chair. I'm going to let you just go.
Yeah.
I'm going to let you do what you need to do. But you keep going.
No, but basically just to say that all these biomarkers are important for the doctors to say maybe, if you have a commutation with STK11 or LKB1, maybe the doctor will tell you more or less you will stay on this treatment for less time compared to the median patients. But it's not that you are not prescribing the drug. You are prescribing the drug, but maybe you don't expect that the patient will stay on that drug for 2 years. Okay? This is what I think is important to understand. All that these things that are important to determine the length of the treatment and not the treatment. And maybe will help also in the future to shape better scenarios where you can have maybe you will know maybe for the STK11 the best treatment will be a pan-KRAS inhibitors, or will be the combination of a pan-KRAS plus a G12C inhibitors, or a KRAS plus an ERK inhibitors. So I'm just inventing now, but just to say that all these kind of things will define maybe in the future the best treatment for each patient. Okay, but now we are including the patients in clinical trials only for the presence or not of KRAS mutations. I don't know what I put more than this. I think that my consideration, as I said before, is that for me, that I have been working in this field for 20 years, I have seen so much advances, and I am so happy that you can imagine how much. So there are many clinical trials, many molecules, and will be very difficult to define if there is a best in class. And we are still working after 20 years for the EGFR mutations, on which is the best in class, the best strategy, the best sequence. So that I think that in the next years, we will have a lot of work just by using or everything that was discovered in the last 3-4 years. I think, as I said before, maybe we can move in the next years to the concept of KRAS G12 whatever, to the concept of G12 whatever plus something else, and maybe define the better strategies for each one of these possibilities. There is a huge work to do on drug resistance, so trials with the new compounds are very important, so the patients maybe can finish the first generation inhibitors and move to the new drugs, again in clinical trials. And there is also a lot of work that we can do together about the toxicity. How can we improve the toxicity, and how we can render your quality of life much better. Just to say something about the toxicity, big advances were done in other fields of lung cancer about the toxicity with patient suggestions. So I think that reporting the side effects and maybe also solutions that you have found, like, type of foods that can reduce the toxicity, or the time in the day, the best time in the day to take the drug, or things like don't do a shower with the warm water because they can increase the toxicity, are things that are not coming from the clinical trials, but are coming from the experience of the patients. And I think it's really important that we talk as much as possible to advance the research altogether in this field, not just in length of life, but also in quality of life.
Okay, well, very well said, very well said. And so the important thing is that we're bringing this information because, you don't know what it is that we're going through unless we tell you what it is that we have and we're facing, okay? It's one thing to see a grade 1 or grade 2 diarrhea on a chart. It's entirely different to not be able to leave the house. It's entirely different to not be able to do carpool line because of it. So that's different. Okay. Now all that being said, we probably could just like drill down for another hour and just lung, and we probably could do like 3 hours on the GI cancers.
For each variant.
Right. Yeah. on each variant and each cancer and stuff. And so if we didn't cover it specifically, I'm going to assure the audience that I've got other presenters that are going to be coming in so we can drill down more specifically within stuff. And okay, hopefully I don't regret saying this. I think I want to do a presentation that is everything but G12C, merely because there's so much other things that are happening. And